constitute severe malaria. In African children, 4 important patterns of illness or clinical syndromes may occur in severe malaria. The 4 syndromes are general body weakness, prostration, severe anemia, distressed breathing, altered consciousness, and/or convulsions. A child may develop just one syndrome or several at the same time. Any one of these syndromes indicates a need for urgent treatment. Other causes may also induce the syndromes that can occur in severe malaria. When you see a patient with fever or with a recent history of fever who also has one of these syndromes, you must consider other possible causes as well as malaria. Let us explain these syndromes in more detail. First, body weakness. Here, there is no disorder involving the other 3 elements, but the child has severe general weakness or prostration and needs to be treated urgently. We say that a child has prostration when it is unable to drink or suck at the breast, or is unable to sit or stand. Second, severe anemia. This child has severe anemia. The palm of the hand is very pale compared to the mother's hand, and the conjunctiva also shows severe pallor. Urgent treatment is needed to save the child's life. This can occur at any age, but is particularly common in infants and very young children. Mothers can best recognize severe anemia by comparing the child's palm with their own, as in this case. Here are other examples of pallor of the palms in children with severe anemia. The conjunctivae of the eyes also appear pale. In this child, there is also some jaundice on the white sclera of the eye. Children can often tolerate severe degrees of anemia without appearing very sick. There are 2 ways to assess the severity of anemia. One is to check the child's condition. Is it very weak? Does it have any difficulty or distress with breathing? Is it lethargic or unconscious? The second is to measure hemoglobin concentration or packed cell volume. This helps in directing treatment, but it is not sufficient in itself, and you need the clinical assessments we have just mentioned. When examining a child with anemia, you may note the size of the spleen, which is usually large in malaria. However, this does not help in assessing the severity of the child's illness. A large spleen is present in almost all children in areas of intense malaria transmission. It is more important in this child to note the deep breathing. Assessing the size of the liver is useful because a rapidly enlarging liver is a sign of possible heart failure. You must note the liver size at your first examination so that liver enlargement can be recognized if there is an increase later. Third, effects on breathing. Any child with fever may breathe rapidly. When you assess a child's breathing, you should try to answer 3 questions. How fast is the child breathing? Is there indrawing of the chest wall? And is the breathing deep or shallow? The sign that best indicates severe respiratory distress is indrawing of the chest wall. As this child breathes, the lower part of the chest wall is drawn inwards. This is an important sign. If a child has respiratory distress, look particularly for deep breathing. This suggests acidosis, the commonest cause of respiratory distress in severe malaria. In the breathless child, look carefully for evidence of pneumonia. Occasionally, an anemic child may have heart failure, suggested by an enlarged liver, raised venous pressure, crackles in the chest, and a galloping heart rhythm. You may also note flaring of the nostrils. This is common, but it is not a useful way to assess the severity of respiratory distress. Another sign commonly noted is intercostal recession, as in this child. This too is unhelpful in assessing severity. Fourth, syndromes affecting the brain. These children have become unconscious after a short fever illness. We have seen that malaria may affect a child's brain in different ways. There may be drowsiness or lethargy, often accompanying severe body weakness. There may be unconsciousness or unrousable coma, as in the children we have just seen. Or there may be convulsions. In this child, who has unrousable coma, the arms and legs are rigid, and the arms are held in a flexed position. This is known as decorticate rigidity. Children with malarial coma may adopt other positions. For example, arching of the back, or opisthotonus. Arching with rigid extension of arms. This is decerebrate rigidity. Sustained postures of limbs, or posturing. In this child, note the sustained elevation of the left arm and of the eyes to the right. Here too, the child holds one arm up in a flexed position. Convulsions, seizures, are common when malaria affects the brain. In a young child with high fever, a convulsion may simply be due to high fever, a febrile convulsion that lasts a few minutes. The child usually regains consciousness within half an hour or less. When not simply due to fever, convulsions in malaria may be single or repeated. They may be simple convulsions of the tonic-clonic type or more complex. They may affect one part of the body or several. Sometimes there may be almost no visible movement. This child has generalized clonic movements that persist for several minutes. The movements involve both arms, shoulders, and legs, and also the head. Note also the twitching of the left eye. This child has a prolonged generalized seizure. In another child, there is repetitive movement of the head and also of the lower part of the body. It is clear that this child, too, has a prolonged seizure. The left side of the mouth and the left eye are also twitching. This is the same child. The head movements have now stopped, but local twitching movements of the left side of the mouth and the left eye are continuing. He is now having focal seizures. Note that the eyes are continuously looking to the right, although the child is unconscious. The child has a repetitive movement of the left leg. Any purposeless, frequently repeated movement should suggest the presence of convulsion. This child also has hypertonicity of the arms, and especially of the right hand. Although the hand is not twitching, the repetitive leg movement we saw earlier suggests that the rigidity in the hand is due to seizure. Note the incontinence of urine that commonly accompanies a convulsion. This child also displays a recurrent grasping movement of the left hand. Again, a repetitive movement like this in an unconscious child is likely to be due to seizure. The repeated and inappropriate cry in this child is also due to convulsion. Here is another child whose convulsion is causing a repeated cry. The associated twitching of the left hand indicates that this child is actually convulsing. Note that the child's eyes are constantly deviated to the left. This is part of the process of the seizure. Sometimes you may need to look very carefully to see any movement at all as a clue to the fact that a convulsion is occurring. This child has very slight repetitive movements of the face and mouth, and this is the only clue to a seizure. In this child, you can see a slight flickering of the eyebrows, which is all that can be seen of the seizure activity. Both these children benefited from treatment for their convulsions. Convulsions may cause frothing at the mouth, as in this child. We will now review the assessment of the child with severe malaria. Remember that in an endemic area, the presence of parasites in the blood does not prove that malaria is the cause of the child's illness. The history and physical assessment are important in deciding on both diagnosis and management. The history for a very sick child is usually obtained from the mother or guardian. Make sure that the history enables you to determine the following things. Has the child received any treatment for this illness, either from a traditional healer or from the health services? How long has the child been ill, and especially how long has the child been unable to drink? Have there been convulsions? If yes, how many? And has the child had convulsions before? Has the child been unconscious? If yes, for how long? Also assess whether the child is likely to need extra fluids, whether there has been vomiting or diarrhea or fever, which also increases fluid loss. The examination should also establish the possible diagnosis and assess what complications are present and what emergency treatment is needed. In measuring the pulse rate, test also for the presence of dehydration or for a cold, clammy skin. Check the temperature and the blood pressure. A low blood pressure indicates an urgent need for fluid replacement. The blood pressure may be normal even if the child is dehydrated. Assess the breathing. Look for the rate and depth of breathing and whether there is indrawing of the chest wall. Look for pallor and jaundice. Assess the size of the spleen and especially of the liver. Ophthalmoscopy can provide information on the presence of papilledema, a contraindication to lumbar puncture, and other signs. If the child is unconscious, turn its head to check for uncoordinated eye movement, doll's eyes, a sign of deep coma. It is very important to look for evidence of convulsions and to note what part of the body is involved and how long the convulsion continues. In an unconscious child, it is helpful to measure the level of coma using a coma score. In the Blantyre coma score, a painful stimulus is applied, first by pinching the child's finger. This child does not withdraw his arm when the finger is pinched. Then a painful stimulus is applied to the sternum and to the bone above the eye. This child does not use his hand to remove the pain. Now the child is improving and quickly withdraws his hand from the painful pinch. The child is able to localize the painful stimulus on the chest and push it away. This child does not pull her arm away from the pain, but she cries briefly. The coma score is discussed in the Learner's Guide on Management of Malaria, part of the management module. This child's mother complained that it had passed blood in the urine. The urine was very dark, but microscopy showed no red blood cells. The dipstick was positive for blood. This is known as hemoglobinuria and is due to severe breakdown of red blood cells with hemoglobin in the urine and in the plasma on the right. It develops only occasionally in children with severe malaria and usually responds quickly to treatment. A finger prick blood sample can provide useful immediate information about a child's illness. Measurement of the packed cell volume, or hematocrit, will help in the assessment of anemia. Alternatively, use a simple method of measuring hemoglobin concentration. Blood films allow us to examine for malaria parasites. The thick film allows us to estimate quickly and roughly the presence and density of parasites in the blood. The thin film is useful for counting parasites when there is heavy parasitemia. It is helpful to perform microscopy immediately so that the diagnosis of malaria can be made quickly. In the absence of microscopy, a child with a suspect fever must be treated for possible malaria. If possible, use the same blood sample to check the blood glucose. A drop of blood is placed on the yellow part of the stick, and the result is read within a minute. This child is hypoglycemic and needs urgent treatment with glucose. Hypoglycemia is common in children with coma or convulsions. If the blood glucose cannot be measured, glucose should be given. If a child has fever and coma or convulsions, meningitis is a possibility, even if there are malaria parasites in the blood. Some doctors prefer not to do a lumbar puncture in the unconscious child. If a lumbar puncture is not done, you must treat for the possibility of bacterial meningitis in addition to malaria. When a child with severe malaria has received treatment and is improving, you can assess the completeness of recovery. This child is able to sit up without help and to take a cup and drink. This boy is still quite weak, but he is able to take the pencil, to pass it from one hand to the other, and eventually to give it back. He can repeat the words the nurse says to him. This girl is being assessed for walking. She is also having a test of vision and of coordination. She is accurately seeing the small objects and correctly placing them in the container. And she can do this with either hand. This is a good test to see how well the child recovers dexterity, although it cannot be used for very young children. Most children who survive a coma due to malaria make a full recovery, but sometimes there is brain damage, as in this child who is uncoordinated and cannot walk or feed himself. This is another child who is left with weakness of the right arm and leg. When he walks, he tends to fall to the right, and he can hold the pen with his left hand, but not his right. These kinds of residual brain damage tend to improve over a period of months or years, but some children are left with more permanent impairments. Thank you for viewing this video. We hope it will help you achieve better identification of severe malaria in order to give these children a better chance of a complete recovery.
Is a presentation, thank you, on severe malaria, and we are going to cover from the clinical and epidemiological definitions, different mortality according to the forms of severe malaria, some issues around diagnosis of cerebral malaria through the fundoscopic, ophthalmoscopic examination. Then we will look into artesunate and some of the side effects of artesunate IV, but also it happens with also oral AL. Then discussing pre-referral treatment, co-infection, and also severe malaria due to other parasites. And there is a lot of confusion around reporting of severe malaria, and very often there is a proxy which is used, is like people which are being hospitalized for malaria. And that's very incorrect because the way the patients are admitted or basically considered in need for hospitalization varies a lot, and it may depend on access to care, on provider, or also the patient preference in many place settings. But if we want to use the definitions, these are the sets. There are a very set of clear criteria for defining severe malaria. There are clinical features of severe malaria, and the video was giving us some very clear indications, as well as laboratory findings. So if one or more of the clinical presentation or one or more of the laboratory findings are found in a patient with confirmed falciparum malaria, this is the definition of severe malaria. And in the past, there was also hyperparasitemia was considered one of the criteria. In the most recent WHO guidance, it is when more than 10% of the red blood cells are parasitized. This is an indication of severe malaria. However, even if it is lower than that, still the patient may have some risk, like treatment failures, or he also may progress to severe malaria in the future. So even if it's not classified as severe malaria, those patients need special attention. And then there is a more, I would say, stringent criteria, which are mainly developed for studies when one wants to look at the impact of different treatment, for instance, parenteral treatment at different interval, different doses, and one wants to have a specific group of patients included in the study. Then there are criteria which are more, let's say, specific to avoid that other diseases are also being included. And this is a good publication, which I'm going also to put on the OneDrive. It's the most recent review of severe malaria that WHO has done. WHO has done 4 reviews over time. This is the last one. And it's a very good, let's say, publication if you want to review most recent evidence around both the clinical, the epidemiological, and the management of severe malaria. Now, cerebral malaria is probably one of the common forms of severe malaria. Is presents with coma and generally with convulsions, and it's very common in falciparum malaria. Clearly, coma is, as every clinician knows, could also be due to other illness. One of the common associated conditions is hypoglycemia, which can also induce in a lack of consciousness or a stupor, coma, like also cerebral malaria. And if a patient has a coma and has some parasites in the blood, it's important to have other indication that this is actually cerebral malaria. Clearly, what we have here in this picture is biopsy, so that's not a good approach that can be used clinical, but this is clearly just for post-mortem in case of autopsy. For patients, the best diagnosis of cerebral malaria is to look for ophthalmoscopic examination and look specifically to some white patches of the macula and some discoloration of the retinal vessels, as you're seeing in this picture. This, in a very good study done in Malawi, was highly correlated with then findings of cerebral malaria in autopsy, unfortunately in a group of children which then was dying, and then there was an autopsy performed. This is also interesting data. We have different level of transmission from areas of unstable, low transmission to areas of moderate to high transmission here at the top. And it gives you by age what are the typical forms of severe malaria. For instance, in areas of very high transmission, which probably do not apply to your settings at the moment, we may have a lot of severe anemia in children at below 2 years of age, and cerebral malaria is less common. In the situation of high transmission, in many places where you live, there is a lot of cerebral malaria which peaks around at 3, 4, 5 years of age, and severe anemia presents in the younger children. And in areas of low transmission, what we have in many countries of your subregion is cerebral malaria may be seen also at all age groups, and severe malaria may present as renal failure. And this is particularly in older children above 10, 15, adolescents and adults. Definitions of severe anemia is quite specific for malaria. It's defined as below 5 grams per deciliter in children below 12 years of age. And for adults, it's below 7 with a parasite count above 10,000 parasites per microliter in the absence of other possible alternative causes of anemia. So this is something which has been observed. There is a difference of presentation of severe malaria by age, but and different forms present, and this is also affected by the level of malaria transmission. When we look at the progression of an infection from the biting, so inoculation of the parasite, there is a period in which the parasites are in the body but not visible. Then finally they present in the blood. And in some people, generally with lower immunity, they become symptomatic. They may progress to severe malaria and death. So this is the natural progression of malaria. And clearly there are many other causes of death, but in some patients, especially children, there is the concomitant presence of another illness with malaria may produce also mortality, and this is what we call indirect malaria mortality, as compared to malaria direct mortality, which is only attributable to the plasmodium itself. If we take the sum, the addition of indirect and direct malaria mortality, we get the total malaria mortality. And if we add to this other causes of death, well, then we have total mortality. And when we look at the impactor vector control, it actually affects the whole chain of progression to direct malaria mortality, but also intervenes reducing indirect malaria mortality. And this is very interesting because interventions like vector control, like insecticide-treated nets, they have a big impact on child mortality, which is beyond its impact on the reduction of severe malaria and direct malaria mortality. Chemoprevention also has a similar impact, but when we look at early diagnosis and treatment or pre-referral treatment and management of severe malaria, they mainly have an activity or an impact on direct malaria mortality. So when looking at clinical studies, this was the first of a series of studies, but very interesting, in children in Kenya, in children under 5, they looked at number which were presenting with impaired consciousness, or children presenting with severe anemia, we saw below 5 grams per deciliter, or children presenting with severe acute respiratory response. And within this number is the case fatality rate. So if a child presents with impaired consciousness, severe anemia, and severe acute respiratory distress, remember the video which was showing chest indrawing as a very important sign, these children have the very highest fatality rate. More than 1 out of 3 is going to die, even with good treatment. And if we look at other forms of severe malaria which do not present any of these 3, impaired consciousness, or severe acute respiratory distress, or severe anemia, the case fatality rate is below 1%. And so very important for a clinician is, you can see here, every child with severe acute respiratory distress, they are at risk of dying, and this risk is higher than with cerebral malaria alone or with severe anemia. So a great attention should be given in training and in recognition of severe acute respiratory distress. The same type of analysis has been done on a much bigger sample size. The study in Kenya was, you saw 1,800 something children, so not very big. But then there was bigger studies done with both African and African children, Asian adults. And you see that there is also big group presenting with cerebral malaria. As I said, is a big form, is a dominant presentation for severe malaria. The case fatality rate in children in pooling all the data was 6%, but if the child also has acidosis, and this may present with severe acute respiratory distress, then the case fatality rate increases to 23%. And if there is also uremia, it's even higher. In adults, the combination of acidosis, uremia, and coma also increases dramatically the risk of death. And so these were on a much larger set of studies. These were the Sequamat studies, the Aquamat studies, where they compared artesunate injectable with quinine, parenteral. They found out that manifestation of cerebral malaria, renal impairment, and metabolic acidosis, these three groups of syndromes or manifestation of severe malaria were the most important in determining the prognosis, so the risk of death, the fatality rate in patients. Now let's look into treatment. Definitely, treatment is very important to save the life of the patient, and if the patient is with cerebral malaria, is also to prevent neurological deficits, which is also an important objective. For pregnant women, the objective is to save the mother, and that's the primary objectives, and because without treatment, severe malaria in pregnancies has around 60% fatality rate. So other issues like prevention of recrudescence, avoiding side effects, preventing drug resistance, preventing malformation to the newborn, these are not the primary objective when treating severe malaria. Now, there has been a lot of studies comparing quinine versus artesunate. And unfortunately, in many countries, we see that quinine is still used by many clinicians, especially old generation clinicians. This is the compilation of multiple studies. As I said, the Aquamat studies were performed in Africa, the Sequamat studies done in Asia, plus a series of studies. And this is a way of presenting the result. Is called the forest plot graphs. It's possible to present the results of studies with their interval of confidence. And if the study is on this line, the one basically means there is no difference between the two groups. If the studies are on one side, it may favor one of the treatment options. So in this graph, moving to the left of one, it's all studies which are favoring artesunate in reducing mortality compared to quinine. So it's possible to look at the overall results for the African studies in children, overall results in adults, and also to compile the results, adults and children all together. This gives a very, very highly significant results of 31% reduction in case fatality rate of severe malaria when using artesunate injectable compared to quinine parenteral. So based on these studies, that's WHO recommendation is very strong and consider high quality evidence to use injectable artesunate for all patients, including pregnant women when they have severe malaria. So the minimum is to give the full parenteral therapy for 24 hours. And after that, if the patient can tolerate oral therapy, then it is given a full 3 days course of ACTs. The most recent guidance is for the children which are below 20 kilograms body weight. They should receive a higher dose of 3 milligram per kilogram body weight per dose, which is larger than the older children or more heavier children and adults, which is a little bit lower, 2.4 milligram per kilo per dose. If parenteral artesunate is not available, then WHO consider the second best option is artemeter intramuscular. And there is an initial loading dose of 3.2 milligram per kilo, which is then followed by daily doses of 1.6 milligram per kilo. And this is the best choice and to be preferred to quinine. So there is basically a 1, 2, 3 order of preference in when treating severe malaria. Why the dose has been increased for the very small children, this is, it's based on pharmacokinetics. They saw that below 20 kilograms body weight, if one uses the 2.4 milligram per kilo, there is a lot of children basically are exposed to lower doses. And if one wants to keep the same level of blood levels, one has to increase in children to 3 milligram per kilo. If this is done, you can see that the artesunate blood levels or the hydroartemisinin blood levels, which is the metabolite of artesunate, they are then kept at the same level as for the older children or adults. So that's the reason why the dose has been adjusted. Now, I will going to put also on the OneDrive folder these job aids. These are very nice, made by MMV. It's something that Dr. Qassem has been with Mariam help and very good in getting the Arabic translation. So I don't know if finally this takes a lot of time for MMV to get it in the final shape. I don't know if this is finally available, but I'm certainly going to share with you the English version. It's something that you can print A4 or A3 format, put it on the wall and help the provider to remember exactly how many vials are needed, how to reconstitute, how to dilute, how to make the preparations, and then according to the body weight, how to give it if it is by IV or how to give it by IM. So very, very well explained and then very clear. And I hope the Arabic version is also going to be available soon. So this is the 1, 2, 3 I was telling you before. Artesunate is number 1, is really the best choice. And if this is not available, one has to use Artemeter. And if neither Artesunate or Artemeter are available, then the quinine can be considered, still life-saving drug. But if you use Artesunate, there is a reduction of 30% of the case fatality rate. So basically you are saving 1 patient out of 3 more when giving Artesunate compared to quinine. This is a graph to show you the blood level of Artesunate versus Artemeter. Artesunate gives a very clear and more uniform peak of absorption, both intramuscular or IV. Clearly IV will be very uniform, but Artemeter is in an oil suspension, is given intramuscular only. And you see that it has a very big variation by patient to patient. So there is variability which may affect the therapeutic action. That's why Artesunate is considered always the first choice by WHO. Now, pre-referral treatment is something which is getting more and more of interest, especially now that there are products available pre-qualified by WHO. They are produced by Strides and Cipla. Is 100 milligram recto caps, and when the injections are not available or cannot be used, so in peripheral and settings, then for children below 6 years of age, a rectal dose of Artesunate in the dose of 10 milligram per kilo is given, and then the child is immediately referred to the nearest facility where the full parenteral treatment can be given. Now, the data are not so clear, and the evidence is actually not positive for older children and adults. So this intervention is only applicable for children below 6 years of age. There are also job aids for how to give rectal artesunate, and again, also done by MMV. So I'm going to share those and put them in your resources folder on the OneDrive. Use of antibiotics. This is an important recommendation because there is a very important overlap in the clinical presentation between septicemia, pneumonia, and severe malaria. And often these conditions may coexist. And especially in the children, it's very difficult to rule out septicemia if they are in shock or they have lost consciousness. Then children which have suspected severe malaria in areas to moderate to high transmission, they should be given, together with injectable artesunate, also broad spectrum antibiotics until a possibility of bacterial infection is excluded. I'm coming to the end, and this is the antibiotics, ampicillin, tamiflu combination, or the co-amoxiclavulanic acid, chloramphenicol, or cephalosporin are the recommended antibiotics to be given parenteral. This is a condition which may follow treatment with artesunate injectable. Is common, especially non-immune and in small children. Sometimes, and I would say most often related to hyperparasitemia at the time of starting the treatment. This patient may have a post-treatment hemolysis around 7-15 days after treatment. And it's something to be then followed up. Some of these children may require even hemoglobin checkup, transfusion if it's going very low. That is rare, but also vivax can give severe malaria, and often is the acute respiratory distress syndrome and or the renal complication, and severe anemia is common in young children, and the treatment is exactly the same as falciparum, but is rare, is not so common like falciparum. This is a study done in Brazil of a series of 17 patients which were dying with vivax after severe vivax malaria. Vivax is present in your country, so it's something to remember. And this is to prepare our next basically session 7, where we're going to discuss about G6PD deficiency. 2 patients in this series were actually G6PD deficient patients which were treated with primaquine, and they had an hemolysis after primaquine treatment. So that's another big aspects of vivax treatment that we'll treat next time.